So we are moving on to second part of mental health um, session. Um, so last time we went through how to measure distress and what is distress, all that we have, and today we will be continuing with the. I hope that there will be something on distress and also some of the topics that you have asked. Um, so Dr. Chitra, who is the founder and director of MEHAC, it is a community-based organization for providing mental health in the community. And she has a lot of experience both in psychiatry and in in palliative care. And presently she's working as the professor of psychiatry at the University of Medical College, as well as the mentor for palliative care. And she has been worked with the various palliative care departments. And with this short introduction, I invite Dr. Chitra for continuing her session. Madam, it's all you.
Thank you, Sunil. I hope all of you can hear me. Can you hear me? Yeah.
Yes, yes.
Okay. So I think Sunil had contacted me and given me a few topics. So what I'm planning to do is I'll just finish the previous presentation for management of distress in like anxiety and depression. Go on to sleep issues a bit, and then if possible, if we have time, just a few slides on self-care. So that's what I've planned, and all three will be different presentations, so I'll have to share them individually. So let me start with just a minute. Can you see the slides?
Yes, yes.
Okay. So we did talk about distress. I hope all of you have some kind of information in your mind, because it's been quite 2 weeks or so, I think. So hopefully you know that we talked about distress, how to identify it, screening with tools, and then how we categorize it when you screen, and then if it's more than 4 or 5, definitely they need help. And then now we are going to how do we manage disabling distress. So there are general ways, or steps that anybody would do in the primary care team to take care of it, the pharmacological methods as well as psychological interventions that we use to manage disabling step. So when you look into distress, more than 4 definitely needs support. And if possible, the interventions should be from a specialist or someone in the primary care team or the or have within the palliative care team, but who has been trained or who has some sense of how to go about the management of distress. So when the distress is mild, usually you give psychological interventions only. And when the distress is moderate to severe in nature, then they need addition of pharmacological methods also. But let me first speak about how do we manage people in distress otherwise. So any person, we can when the palliative care team, because you have been trained with communication skills, you can actually do much of this management on your own in terms of maintaining therapeutic interaction. How do you maintain emotional closeness, maintain the distance or keeping boundaries is an important skill to learn. Psychoeducation, how do you educate them about the distress? How do you give them appropriate ideal information so that they can manage their distress? And how do you normalize some emotional reactions. Like when we talked about emotional reactions, we did say that distress can be, the sadness can be is normal also, and it actually crosses, a boundary to become pathological, isn't it? So some of the reactions, like we talked about grief, um, so when there is a loss, when you have grief, and when you the immediate few days after getting a bad news can be full of distress, but then at that point we can understand that the person is going through it, and actually it could be normal emotional reactions. Help in enhancing coping competence, that is to help the person ventilate and validate, how to manage crisis, help in problem solving, and using other patients and families to support them, that is a peer group support. And remember, I showed you also how people can express the symptoms of distress, and one was the somatic symptoms or the physical symptoms. So you have to address the um, somatic symptoms. So let me just go about the elements of psychoeducation. So the importance of therapeutic interaction in terms of evaluating and exploring distress is very important. So using your advanced communication skills, you have to actually look into what is beneath the statements they have, the questions they have, the emotional expressions they show, and also to understand what do we do when a person is crying, or what do we do when a person is angry or tearful, when a person is in denial, as a coping mechanism. So we need to have that very strong therapeutic interaction to address all those things. Clarification is a very important component of communication. That is when you simplify complex facts. It is a two-way conveyance of information. It's not a single way conversation. It is a mutual, it should be patient centered, but mutually discussed agenda, and help in enhancing coping competence. So I'm just going through what you already know in terms of psychoeducation, in the sense that check the patient's knowledge of the illness, explain only what he does not know, as well as correct the misinformation or deficiencies in their knowledge, provide details of the diagnosis, elaborate finer points in easily understandable language, use short sentences to make points clearly, and avoid medical jargon. Check the patient's understanding of the problem, that is the distress itself, with a query whether the patient has further questions, in a manner assuming that he has some questions. So this to really go back to practicing your communication skills is very important. Often in clinical practice, we do it so often that we actually uh, are not aware what we do in daily practice. We it becomes a bit mechanical. So each time it is good to stop, pause. That's why in communication skills, the supervision and feedback from your own colleagues is very important, so that you are always aware of how you're doing it. So practice, you keep practicing with supervision, then that makes your communication skills much better. um, Steps in psychoeducation, again, providing basic diagnosis, respond. So this is very important, how you respond to the patient's feelings about the diagnosis, helping them to assist to verbalize and express emotions, and also how to provide realistic hope. So to avoid unrealistic hope, but to bring that gap, closer between the unrealistic and realistic expectations that a person has, along with appropriate emotional support. So in coping, how do you enhance the coping competence of the person? So it's by ventilation and validation. It's very important that we all of us do this. We help the person say things, isn't it? So we always say, when you share the burden of your heart, it becomes half, isn't it? So when the heaviness actually reduces when you start talking to someone about your illness. So illness or your distress or whatever suffering you have. So to facilitate that process of ventilation and validate. So how do you validate? Validate is the non-judgmental and non-confrontational method of listening to them. So we are not saying that you are right or wrong. We are not questioning them. We are not putting them in their place, but we are just listening to them, making sure that making sure that you are giving them the message that you are there with them through this journey. So that that validation is very important. Often this is a basic step of supportive psychotherapy, and you have to know this to offer support to a person for emotional distress. Problem solving therapy is a type of cognitive behavioral therapy where you have sessions with the person and you focus on their resources and not on their deficits. So then you start prioritizing their problems and you address the problem which is the priority for the patient. So remember that this is thermometer and we had the checklist of problems. So each time those problems can change. So you identify that problem and you do not offer solutions. So we have this habit of fixing problems and we think it's our job to do so. But actually you just facilitate the process. You help the person themselves look at what resources they have and find whatever possible ways to address a solution. Often we are not able to solve, but we are able to address the problem. So you focus on the resources and not on the deficits. Crisis management, very important, very common in palliative care treatment, isn't it? That you end up with urgent issues almost on a daily basis, but help the person to, you know, look at the crisis or look at the problem as and find small realistic goals every day. Let's see how we can manage this today. How do you do that? Can you tell me what support do you have for that? So those kind of questions to facilitate the process. You need not offer any solutions to manage the crisis. You facilitate the process. Of course, at some point when the person says that, doctor, please help me, then you do offer some strategies, but then initially you just facilitate the process. Help the patients themselves, rise up to being experts of their illness, especially ones who have recovered and can reassure others, and strengthen the potential of the family, that help them understand to what they can actually do in this unusual circumstance. So sometimes this was something which we did very effectively during the COVID times, where it was such a difficult times for people with COVID infection and also the family members, the carers. So and the main issue was how to manage through the difficult situation. So to address how they could cope through that difficult time was very important. And then bringing in meaning into their lives, bringing in meaning to what they do is very important. So this is almost touching the spiritual aspects or the existential aspects of therapy, of helping them, finding them ways where they can connect inwards. So try to look inwards, try to look outwards and upwards. So your faith, your connection with nature, harmony, your connection within you, looking into what are your strengths, how do you help yourself, looking into the supports you have outside in terms of family. So all this, and especially in terms of how a person has been using such ways to alleviate himself in times of suffering is very important. So now that those were the very simple ways that I said about looking into how you can actually start the process with just non-pharmacological methods. And now we are going to talk about pharmacological management. So remember that we were talking about anxiety and depression in terms of how we categorize. And when it's an adjustment disorder, usually we address with supportive and therapy, with problem-solving therapy. We give medications in adjustment disorder only when there is significant symptoms like insomnia or panic attacks, something. Otherwise, if it's a mild disorder, we do not immediately start medication. But if the person has significant anxiety or whether the person is moderately depressed, the first medication of choice for anxiety and depression is antidepressants. So, and along with antidepressants, you might add benzodiazepine if there is a significant anxiety. So even when it is anxiety, it is not only benzodiazepine that you start if there is significant anxiety. So you start with an SSRI, that's a selective serotonin reuptake inhibitor, in small doses and slowly titrate up. It takes at least 2 weeks for specific changes. The common ones used are fluoxetine, escitalopram, sertraline. You have paroxetine, many others. I've just given a few examples and their ranges. Fluoxetine around from start slow, low, and slow. Slow and slow is the slogan. 10 milligrams to up to 60. I mean, as psychiatrists, we go fluoxetine, we go even up to like 100 milligram, but we go very slow monitoring. Escitalopram 5 to 20 milligrams, sertraline 25 to 150 milligram. Usually, SSRIs do not have major side effects, especially, uh, uh, but we have to educate them, saying that there could be some nervousness in the initial few days, and ask them to hold on, because people might stop it thinking the anxiety is actually getting worsened. But there could be some anxiety, and in older people, there could be gastritis or gastric bleeding, and of course, hyponatremia in elderly with SSRI. So we have to be careful to start SSRIs in the elderly. Other useful medications are SNRI, that is serotonin norepinephrine reuptake inhibitor. So this is like a modern tricyclic antidepressant where it acts on both serotonin and norepinephrine, but do not have much side effects compared to the tricyclic antidepressants, which has a broad range of effects as well as side effects. So you must be familiar of venlafaxine and duloxetine. You also use them for neuropathic pain, just like uh, tricyclic antidepressants are used. Venlafaxine, the range is 37.5 to 150 and duloxetine 20 to 40. When you increase the dose of venlafaxine, you have to be careful about hypertension of the person, because initially it's the serotonin effect, and then when you increase the dose, the norepinephrine starts acting, and so the effect on blood pressure um, is expected. So when a person has hypertension, you have to monitor them. NASA, or the noradrenergic and specific serotonergic antidepressant, very commonly and usually use mirtazapine. Mirtazapine, the range is from 7.5 to 30 milligram. Low doses of 7.5 usually used even for people with sleep disturbance, especially when they have associated anxiety as well. Mirtazapine also helps in improving the appetite a bit. So it's a good medication to start with when a person has anxiety and sleep disturbance. Tricyclics, the most evidence which comes because it's been used for years. So the question is why they should be used. It's because we know about tricyclic antidepressants so well, like amitriptyline, imipramine. So many tricyclics are present, but why not? Because they have a lot of side effects, anticholinergic, antihistaminic, so we do not need to use them, because especially in older people, they can precipitate glaucoma, urinary retention because of their anticholinergics. So, but if you have already started a tricyclic for neuropathic pain, and if there are no side effects, there is no harm in trying to increase it slowly, monitor, but do not go beyond 75 to 100 milligram. uh, you can add in an SSRI also with a tricyclic. But at that point, if you want, you can take the help of a psychiatrist. Trazodone is another antidepressants in the same group. It is useful in insomnia and anxiety. You have to start very low against taking care of the side effects. It is known to be, there is evidence to say that it's useful in insomnia. Uh, Start in low doses. Let me come to benzodiazepines, because it's one of the commonest group that we use in many aspects, and of course in emotional distress. You as mental health professionals, we see prescriptions from physicians sometimes with using benzodiazepine indiscriminately, because people just use when there is uh, they just say tension, and then there is a alprazolam coming in the prescription. And but what happens is that the alprazolam is continues indefinitely, or there is no follow up. And there was a time when people could buy it over the counter as well. Now it's very difficult for people to buy such medications over the counter without a prescription, though some people do manage still now. And long term use of benzodiazepines, especially in the elderly, causes a lot of side effects and can lead to a lot of cognitive impairment also. So it is useful. Of course, benzodiazepine is a very good group of medications which we use very commonly. It's useful for acute anxiety, especially panic attacks. But it needs to be tapered off after the acute episode, unless, of course, when you see them in terminal states, you do use them continuously when you know that their time is short and your main intention is reduce suffering. The common ones used is lorazepam 0.5 milligram to 2 milligram, once to TDS a dose, clonazepam 0.25 to 1 milligram TDS, maximum 4 milligrams per day, and midazolam given subcutaneous or IV 0.5 to 2 milligram per hour, especially in terminal states. So very useful, but be careful. So when you start SSRI and you think there is significant anxiety along with, it might, because they take the antidepressants usually takes 2 weeks to really, come into action completely, more than 2 weeks sometimes. So then you need a medication for the person to actually, get reassured and some symptoms to come down. So you start as a combination, but after 2 to 3 weeks, you start tapering the benzodiazepine. Psychological interventions are relaxation methods like deep breathing techniques, yoga and meditation, progressive muscular relaxation. You can use this in people who have chronic pain. Sometimes terminal, people in terminal states or end of life may not be amenable, or may not be, you cannot really subject them to such uh, techniques. But in children, and like, and in people who are not in the end of life stage, but in the initial stages, have remitted, are stable in their cancer journey or other illnesses, you can actually help them reduce the anxiety using these distraction methods like imagery, especially in children. Hypnotic methods and imagery have evidence shows that they do help the person. CBT or cognitive behavioral therapy, one of, you have a lot of evidence in palliative care as well as in oncology, psycho-oncology, especially supportive therapy and problem solving therapy. People who are interested, please do read about it. I'm not going much in detail because I think, as a primary care team, in terms of emotional distress, I would expect you to offer supportive therapy, start the medications, and if it's becoming difficult, refer to a mental health specialist. There are other therapies which have been mentioned in psycho-oncology, um, like the family therapy, especially because a lot of interpersonal and family relationships get affected with chronic disease management. And the outcomes are also, very difficult for us to manage when you come, especially at end of life care. So a family focused intervention, directed crisis intervention, and also focusing on promotion of family unity. Conflict resolution is very important, especially in end of life, as we say, because the person themselves might want, either, if there's a conflict with siblings or the children, or conflict between the children, sometimes they themselves would want some kind of a closure. So we need to really explore and use advanced communication skills to check on the conflict and help in facilitate conflict resolution. There is newer evidence for meaning centered therapy. A lot of evidence is coming up for meaning centered therapy and dignity therapy, which looks into, especially into how a person would look into meaning, like, how, what the hopelessness, what meaning and purpose they have in life, and how dignity can be maintained. What is dignity to them? How do they define dignity? And how that can be facilitated for that person. So these are the some of the psychological methods that we use to address distress. So I think that's done in terms of distress management. I'm just stopping here for now. Stop sharing. We can just have 5 minutes to discuss, and then I'll go on to sleep. Any questions?
Some of these patients are also dementia patients, and sometimes I have seen them having severe hallucinations. So
Yeah,
how can we deal with that?
so when I've not touched on dementia at all because there's no time in 2 hours to do everything. So dementia, usually we have to be very careful. So as guidelines would say, you use non-pharmacological methods essentially to start with for dementia as well, in terms of look into the triggers that is making them agitated, because there's a lot of agitation and anger, irritability. They behave, their personality itself sometimes changes. So uh, we need to really, because what happens is often when they are demented, even the family members would keep asking them about their memory, or do they remember, keep reminding them, keep telling them things which probably they are not able to do, and pointing out so many such small triggers which the family members are not aware of at all. So we need to really, or some physical symptoms, somatic, like, urinary retention or even incontinence, or, pain, which the person might not remember to complain. So you have to really have a continuous kind of follow up of such people to find out what is actually triggering the person.
Mhm. Yes, ma'am.
So that's very important. But I can also understand that the behavioral and psychotic symptoms in dementia are sometimes unmanageable, and people become very violent or aggressive, or they run away, they get away from home and go wandering. They do not sleep through the night. They keep muttering, they keep walking, pacing up and down. So then you do start on some medications. So if you can assess the person yourself, look into, whether there are psychotic features like delusions and hallucinations. Sometimes people might have some mood symptoms also. So sometimes an SSRI helps in some people if there is mood symptoms. um, Otherwise, you start on a low dose antipsychotic after discussing with your team as well as the family members, saying that, see, antipsychotics, like if even for delirium, if you look into the new evidence coming, especially from the Australia by Meera, the articles by group led by Meera Agar, they say that the evidence now is that, non-pharmacological methods are is what we should actually look into, because uh, they say antipsychotics also sometimes worsen the delirium or because generally antipsychotics do worsen when there is a neuronal injury. The side effects come off well. So you have to be careful, but we have to keep a balance also, because sometimes uh, they deserve to be managed with antipsychotics. So start off with very small doses of antipsychotics. I would usually start only either on quetiapine, start from 12.5 milligram and slowly increase, or aripiprazole, 2 milligram to 5 milligram. I would think twice, or or even discuss before I would start risperidone, which has a potential to cause extrapyramidal symptoms. Not, I would never probably start haloperidol unless there's an overlying delirium, and then we can taper it off quickly. But then if it is manageable by an atypical antipsychotic, I would use only that. Olanzapine and risperidone also have some reports saying that, they actually have vascular episodes, like thrombosis and some.
Yes.
So you have to be very careful. So if you could consult with the psychiatrist at that point in time and then have a license, that would be very good.
Okay.
But
Because this
quetiapine
affects
is,
the family,
yeah,
it
but
affects the family a lot,
yeah,
and then even the
quetiapine
family
is
goes in for a breakdown.
quetiapine is quite useful. And
Okay.
as psychiatrists, sometimes we use, when it's a lot of agitation, small doses of clonidine we use to reduce agitation. Very small doses, monitoring their blood pressure, a very, very small dose, and then monitor. And sometimes the agitation comes down. And we also sometimes use an atypical antipsychotic called clozapine, which uh, which only psychiatrists are very confident of using it. So I wouldn't advise you all to start it. But clozapine, small doses, especially because its propensity to cause EPS or extrapyramidal symptoms is much lower than the other antipsychotics. But especially it is useful in some dementias.
Thank you.
Yes, thank you. Any other question? Shall I start off with sleep?
Yeah.
So just what's happening? Going into slideshow. Just let me just do it once more. PowerPoint has just got stuck. Just a minute. Okay. Okay, some sleep. So sleep issues are really common, both in primary care as well as in palliative care. Almost 60% of people do complain of sleep issues and impaired sleep despite adequate opportunity and circumstances. That is actually sleep disturbance. It's not. So whenever there is sleep disturbance, you have to find out their pattern of sleep, because some people, despite having good, having a good amount of sleep, they're not satisfied by sleep. So with the sleep they have, so you have to really check on what is wrong with the sleep, rather just say insomnia. So it is not insomnia always. So we have to be careful while we term people with sleep related issues as well. So there could be difficulties in initiating or maintaining sleep. That is what we call initial insomnia. It could be waking too early, that is early morning insomnia, experiencing sleep as non-restorative or unrefreshing, and then also having daytime impairment. That is, they sleep, try to sleep, have interrupted sleep, and they have daytime impairment. The associated factors again to disturb sleep could be the physical symptoms, especially pain, mental health issues like anxiety, depression, psychotic symptoms, the medications that you're on, environmental factors. It could be cold, it could be too hot, it could be, the room that you're sleeping in or the people that you're with or whatever, the functional status of the person. Sometimes when the person is bedridden, the person sleeps through the whole morning or the day and does not sleep at night. So you have to look at functional status, or whether the bladder and bowel functions and etc., and medication side effects, especially the psychotropics, then steroids, the neuropathic, the analgesics we give for neuropathic pain. So, but there is increased evidence of insomnia in nearly 70% of cancer patients, between 30 to 70% of patients with COPD, between 74 to 98% of patients with Parkinson's disease, and at least 1/3 of patients with chronic heart failure. But in general, uh, it's an issue when the delays is more than 20 minutes for children and young adults, and more than 30 minutes in falling asleep for older adults. Periods of awakening more than 20 minutes for children and young adults, and more than 30 minutes for older adults. And in general, waking up more than 30 minutes before normal waking time. So this is about setting of sleep in between interrupted sleep and the early morning awakening. So there is an international classification of sleep disorders. There is a diagnostic criteria for chronic insomnia disorder also. I'm not going to talk about it in detail, but it's about, they should have difficulty initiating, difficulty maintaining, waking up earlier than desired, resistance to going to bed on appropriate schedule, and difficulty in sleeping without parent or caregiver intervention. So they should have at least one or more of these. And also, in addition to that, they have fatigue, attention, concentration, memory impairment, impaired social, family, occupational performance, mood disturbance, daytime sleepiness, behavioral problems, reduced motivation, proneness to errors, concerns about dissatisfaction with sleep. So, and this is not explained by any other illness. And also, provided the person is given adequate opportunity, that is enough time to sleep and adequate circumstances. So we have to rule out all those when we make a diagnosis of insomnia. There are some tools as well, just to give you, for you to read up if you want to. There's a Pittsburgh Sleep Quality Index, which has 19 items and looks at subjective sleep quality in the last month. So 5 items are filled by the partner. And there is Epworth Sleepiness Scale, which has 8 items, which is subjective daytime sleepiness. And there are also self-reported scales. How do we manage sleep related issues? One is, it has to be an active management, not just a prescription of a benzodiazepine. So we have to take into account the overall clinical status. And it has to be an individualized approach because it differs in people, and also people with relatively better prognosis to end of life care, and also medications used, drug-to-drug interactions, and side effects. So we have to, and also about the person's own sleep pattern, before. And some people before the illness sets in also would be having sleep disturbances, which you have a good understanding of that. And we have to treat potentially reversible or manageable symptoms like pain, cough, anxiety, depression. There are not much evidence-based guidelines for management of sleep. So I'm going to give you what I gathered from um, studying a bit of evidence. So again, non-pharmacological interventions are supported much. There are only few studies but a wide variation of interventions has been brought. So one is about addressing environment, keeping the room cool, well ventilated, low light at night, limitations on the use of television, loud music, computers, smartphones, iPads, etc., and also the white noise. Lifestyle modifications, spending time out of bed each day, especially during hours leading up to bedtime. You have to spend time. You come to the bed only when you want to sleep, not spending, if you lie down on the bed always, then you have a tendency to sleep in between, and then your difficulty in falling asleep also comes up. Avoiding daytime naps, especially late in the day, limiting large meals or excessive fluids at bedtime, and avoiding stimulants like caffeine, particularly late in the day. Exercise, there's meta-analysis in patients with cancer, but it's found inconsistent results due to heterogeneity of trials. But generally there is a sense of understanding that if you take a walk, or if you exercise mildly or moderately, your body actually becomes energized, but also you fall asleep well. But there's not much evidence. But a meta-analysis in 2020 of 27 trials on aerobic exercises and mind-body exercise improved sleep outcomes, duration of effect longer for aerobic exercise. But it's difficult to extrapolate to palliative care population, because again, for us, exercise is not one of the major interventions that we can do in our vulnerable population. Of course, this is something which we should take care of: beds, the physical comfort that a person has. So one is about a pressure relief. So water beds, though less used now, cover with a thick blanket if persons are using water beds if they're bedridden. Air beds, of course. There are also evidence to say that use of foamic crate or memory foam over these beds, so that it gives a good kind of cushiness for the person and pressure relief. But for our people, sometimes you're not able to buy any of these. Of course, we are able to issue water beds. I don't know if people use water beds that commonly now. Air beds are commonly distributed in palliative care in Kerala. But help adapt and use local resources to make the person comfortable in our settings. So what do you do using local resources in your own settings, in your settings, in that home, in that family where this is influenced by the socioeconomic status to a very great extent. So we cannot just say buy an airbed to a very poor family unless we can issue one to them. Ensure that the person is kept dry, checking the bladder and bowel care, use of appropriate measure for incontinent persons. So, you either, if we are able to provide diapers, or you are going to, they're going to have catheterized bladder care. So we have to be careful about that. Skin care should be taken care of, because skin with infections, itching, pain, wounds, all that would be important. And also avoid litter, ants, insects, mosquitoes. Very, very important, because I've seen a lot of people, when they come from very poor family, and sometimes they lie on the mat on the ground. You can see ants crawling around the mat or across the mat. Very, very important to check for these things when you go for home visits. Sleep-wake cycle. So this is important to understand that circadian rhythm plays a very important role in sleep. So we need to understand that, because we also need to understand that many medications that we prescribe also affect sleep-wake cycle, especially steroids. So steroids that's why steroids precipitate delirium as well. So delirium is very much related to the sleep-wake cycle, because it disturbs in circadian rhythm. So you need to understand how the person's circadian rhythm is maintained. So modulate that, help introduce familiar routines, alternate bedtime routines, avoid stimulants later in the day, like caffeine or any medication also. Like sometimes you must have heard of methylphenidate, which is, prescribed for children and also adult ADHD, also for fatigue in excessive fatigue in cachexia related fatigue in palliative care. And also it is uh, said to be one medication that you can use in resistant depression in palliative care as well, because it's also its effect comes very quickly, much more than SSRIs. So but it's a stimulant, so you have to be careful. That's why when we prescribe methylphenidate, we don't give it later in the day. We give it in the morning and afternoon, late afternoon. In dementia, movement, activity, exercise, important. Exposure to daylight for at least an hour every morning, again for circadian rhythm. Minimize disruptions, try to maintain a calm, quiet sleep promoting environment. Medication or other care measures performed only when the person is awake. So plan well, help in planning. Try to avoid medication administration, changes in dosing, parenteral doses, giving fluids or food during night. So when the person is hospitalized, this is what happens. There's a lot of disturbance in hospitals. So that is why delirium is common in elderly people who get one reason that they get, delirium is precipitated by hospitalizing the person because of there is a change in the cycle and sleep also. So, you're disturbed a lot for parenteral doses, giving fluids and food during the night, and also visitors. So limit visitors when a person should not be disturbed. Behavioral therapy, the first line treatment is the behavioral therapy, although here there are no prospective data to demonstrate efficacy. Applicability in palliative care is unclear as well, but then we can try sleep hygiene training. So I'm sure all of you would have heard of sleep hygiene measures. You have a set of instructions that you can give the family as well as the person if he is amenable or cooperative to follow, so that the sleep is improved. Cognitive behavioral therapy, again, like to look into the pattern, the emotions associated, the thoughts coming up, the behavior that leads to insomnia. Mindfulness meditation is beneficial in hospital settings, and relaxation techniques. So it's a multi-component measures that we have to use with clinical discretion. So we need to really try with the knowledge that we have. There's not much of evidence-based therapy. But then symptom management is also probably what people are looking for when we talk about sleep-related issues, because people want a quick resolution to issues in sleep. So what do we usually do and why? So usually what I think people do is that they prescribe benzodiazepines, and sometimes indiscriminately and continuously. And actually, when you prescribe benzodiazepines, the danger is that after a few weeks, you have to prescribe more, and the need for benzodiazepines keeps increasing because the person develops tolerance. So we have to be careful, and that's when the person starts, going buying it out over the counter. So the person might be taking at night, the person takes double the dose, and sometimes in the morning also. So it becomes difficult. And why do we use it? Because we want quick resolution of symptoms, and we think that uh, we will be able to manage with benzodiazepines only, which is not so. Of course, benzodiazepines are useful. You should give if it's appropriate for the person. Like if the person is coming with significant anxiety and panic attacks, definitely give benzodiazepine without any other thought with an SSRI. So when you think about pharmacological agents, the points to remember are: you attempt non-pharmacological interventions first. You have to remember that palliative care population has varying sensitivity and risk. Like we did discuss about dementia now and delirium. So in delirium also, benzodiazepine is said to be one of the medications used, but only after trying out an antipsychotic. So you do not just use lorazepam as a first line for delirium, even if in the ICU, but usually people do that also. They just use it as the first line. But people with neurological impairment like dementia, Parkinson's disease, stroke, elderly people, because they do have senile dementia sometimes. All of them react to benzodiazepines in a very varying manner. Some of them are very sensitive and there is a risk. So, and sometimes some other medications which I'll talk to you about also have a risk. So we need to be very aware that about the sensitivity and the risk. And we have to communication, especially of the risk benefit ratio, and discuss with other professionals also involved in the care. Treat associated symptoms related to the disease, previous history of use of sleep medications to be, and explored mental health history, substance use, because alcohol use and any other substance use, very important to know. If the person has been on alcohol use for years, there might be disturbance of, and also small doses of benzodiazepines might not be useful to him. So start with the lowest effective dose of any medication that you would prefer, and gradually titrate. And revisit your decision to use medications for sleep and overall strategy regularly. So these are general guidelines that you would think of when you're looking into sleep-related issues. So in associated symptoms, let me give you examples. If the person has delirium with sleep disturbance, prescribing zolpidem or benzodiazepine or diphenhydramine may worsen the delirium. So sometimes diphenhydramine antihistaminic is also used. So we have to be careful about zolpidem is one non-benzodiazepines hypnotic that is usually used. We have to be careful when we use zolpidem because it can worsen delirium. It can cause sleepwalking in people. It can cause episodes of, irritability. So we have to be careful before using that drug. In end-stage COPD, they may have worsened respiratory function with continued benzodiazepines. In a person with anxiety and depression, continued use of benzodiazepines only worsen. Antidepressants are recommended with benzodiazepines during the start of therapy and for acute episodes of anxiety. So as I said, that's something which I have told you. I'd probably reiterate it again. So these are examples of associate symptoms, and other examples are pain. When you have pain, you do not need to add benzodiazepine along with an analgesic. So wait till the analgesics is at an effective dose and is addressing the pain rather than adding to just benzodiazepine because of the sleep disturbance is happening due to pain. If you just give benzodiazepine because the person might say sleep disturbance and you just give inadequate analgesics, that might worsen pain and also worsen the sleep. So one group of medications that you can use again is antidepressants, because much of the sleep might come from basic anxiety or low mood. So you have to explore for any signs and symptoms of anxiety or depression. And if so, start on SSRIs. That will help. You can taper off the benzodiazepine after 2 to 3 weeks, and that will help the person. Another medication is doxepin, again an antidepressant. Low doses of 3 to 6 and 6 milligram are very effective and safe for short and long-term insomnia. It acts through resynchronization of circadian rhythm. I have no experience of using it. This is from evidence. Trazodone, yes, I have used it occasionally. Atypical serotonin antagonist and reuptake inhibitor, like I mentioned before, it moderates cortisol suppression, 25 milligram to 100, but start with very low dose, even 12.5 milligram. And as I mentioned, mirtazapine, a NASA noradrenergic specific serotonergic, 7.5 milligram to 15 milligram. It's helpful for appetite stimulation as weight gain and nausea. So it's very useful for multiple drugs. So if you look at all the symptoms and you think that, you can use mirtazapine for several symptoms together, that's good. So you can reduce the multiple medications for the person. This is another medication that we use commonly, tianeptine. It's an atypical antidepressant. It enhances the synaptic reuptake of serotonin without affecting norepinephrine and dopamine uptake. This medication is available as Tablon in India. So it's available as 12.5 milligram. You can start as BD and then go up to TDS. At least I think it's like one tablet is cost ₹10. It's very useful, especially particularly in a elderly person and elderly person with other comorbidities. So with depression, anxiety, or sleep disturbance, in an older patient. If you worry that the person would have hyponatremia with SSRIs, other than mirtazapine, stabilon is a good antidepressant that you can use regularly. So this is zolpidem, though it's a benzodiazepine receptor agonist. So it was commonly used, and now I see less prescriptions with zolpidem. For persons with respiratory issues, limited data suggests that they may be safer than benzodiazepines, while previous studies suggested they do not predispose patients to tolerance with long-term use. Subsequent data show that dependence may develop. So there is a question of dependence with zolpidem also. And as with benzodiazepines, this group is also associated with the risk of adverse effects, and patients should be carefully selected and monitored. So one study identified that hospitalized patients may be at an increased risk of falls with zolpidem. So we have to be careful when you use zolpidem. And I would advise that we use other medications first, and then when you want to use zolpidem or other medications, you discuss with a mental health professional. So there are other medications which are non-benzodiazepine, benzodiazepine receptor agonist, zaleplon, zolpidem that I said. So there is zopiclone. So a lot of medications which you can read up if you want. I don't use this very commonly. Other anticipated problems with limited data is that there are problems along with opioids. So patients already on opioid therapy, studies reveal that initiation of non-benzodiazepine hypnotics was associated with an increased risk of mortality. These are all just limited data, but we have to just keep them on mind. And with substance use, it is felt that the risk of misuse of this class of medication there is a potential for triggering relapse. And they are also associated with complex sleep behaviors, like I said, for zolpidem, that have resulted in serious injuries and death. So these behaviors can occur after the first dose or after long periods of use, even at the lowest recommended doses. So we need to be careful when we start these medications. So another group, another medication that you can use is melatonin. Melatonin, because it's quite, the side effects are much less. So this is one medication that I would suggest that you can keep in mind. This is mainly for the sleep onset insomnia. It also acts on the circadian rhythm. That's why it's also used for jet lag and sleep issues. It's an agonist at melatonin receptors, including those in the suprachiasmatic nucleus, which also is involved in the circadian rhythm maintenance. So it facilitates sleep onset by decreasing the suprachiasmatic nucleus driven arousal and helps to reinforce the circadian periodicity. So use of exogenous melatonin has been extensively researched, but in research, it shows only small benefits for sleep onset, but it's not useful for sleep maintenance. So people who find it hard falling asleep, you can start melatonin. It has also to be noted that in a systematic review in 2020, there were 12 meta-analyses of placebo-controlled randomized trials. The authors concluded that melatonin results in statistically significant but small improvement in sleep latency and total sleep time. So there is a lack of consensus on whether the effects are clinically meaningful, but it is worth trying if you want to with your people, if you think that they have a difficulty in falling asleep. It's available as 3 milligram tablets and costs around 3.5 to 4 rupees per tablet. In palliative care, there is no prospective data to confirm, but it is modestly effective in reducing the initial sleep latency and sometimes also in the early morning awakenings. So you can try in our patients also. There is another medication which I have no experience using, but evidence says so. There is a selective melatonin receptor agonist. It's called called Remeltion. It's approved for treatment of insomnia in United States and Japan, but not Europe. It can potentially help people with sleep onset problems or sleep phase depression. In contrast to benzodiazepines and benzodiazepine receptor agonists, it's non-habit forming and does not appear to have side effects associated with others. But it does have important drug interactions that should be carefully considered, especially in palliative care, because in palliative care, you have people having different medications. It's metabolized through the cytochrome P450 1A2 pathway. It is not particularly potent, but probably works primarily to augment the circadian signaling. So It is sufficient. It is a safe choice if you want to try. It's available as a single 8 milligram dose to be taken within 30 minutes of going to bed. I have no experience using this, but it should be avoided in patients with severe hepatic impairment. And the most common side effects are somnolence, dizziness, fatigue, nausea. There is no abuse potential. There are no trials of Remilton in palliative care addressing the benefit and risks, but growing evidence suggests that it is safe. And in our view, a time-limited trial of Remilton is reasonable for carefully selected patients, as long as you are frequently looking at efficacy and side effects with careful monitoring. So I come back to benzodiazepines. If you have to use them for, as part of anxiety, depression, or, sometimes you also use clonazepam when there are, restless leg syndromes, sometimes an adjuvant for delirium, sometimes in dementia when the agitation is too much, not controlled by antipsychotics. So in many situations, benzodiazepines does come to a rescue. So there's several, as you would know, I have already mentioned few. You also have nitrosapam, which is used in psychiatry a lot. Temazepam, flurazepam, quizazepam, estazolam also recommended. Many are not available in India. So I think we commonly use lorazepam, clonazepam, and midazolam in palliative care, and sometimes alprazolam as well. Of course, we use antipsychotics as well, just like discussed earlier. We can use small doses of quetiapine, 12.5 milligram, especially when the sleep disturbance is associated with agitation or with delirium or with psychotic symptoms like delusions and hallucinations. When haloperidol can be used in delirium, olanzapine 2.5 milligram, but not in elderly if possible. But if it's only you don't have anything else to use, you use it and then carefully monitor it. Prescribe usually only after considering associated symptoms. Newer groups of drugs are coming in. One is the orexin antagonist. The name of the drug is suvorexant. It blocks neuropeptides, orexin A and B, which promotes wakefulness. It also has minimal adverse effects and no withdrawal or rebound insomnia. It tends to be relatively high cost. Not sure whether it's available in India also. But when we talk about sleep-related issues in palliative care, we should also look at the impact to caregivers. In a systematic review, 72% of caregivers reported moderate to severe sleep disturbances, and caregivers' sleep quality can be enormously affected, as we know. And that can lead to irritability, anger, guilt, and the overall ability to care, and this leads to a vicious cycle. So it has to be taken account to ensure the quality of lives of the family also. Okay, I'm stopping now. And let us have 5 minutes to discuss this and then go on to self-care.
Now, how long can we give haloperidol for as an antipsychotic?
I mean, haloperidol, it depends on for what you're using it. I mean,
Yeah,
like,
again, so for hallucination.
it depends on what condition the hallucination is not a condition, it's a symptom, it's a sign. So it can be part of dementia, it can be part of delirium. It can
part of dementia, as a part of dementia,
It depends on whether the person is able to tolerate it. I wouldn't start it for dementia because Serenase or haloperidol or Serenase is a typical antipsychotic. So it has got its greatest potency to cause extrapyramidal symptoms. So for delirium means it's a short period. You can stop after the delirium is resolved.
Yeah, delirium I do use, and it's a very good,
but dementia, I would think twice. I would probably choose the atypical.
What would be the best and appropriate? Quetiapine will be okay now, because I got one patient who is having terrible problems.
Or aripiprazole, but if dementia patient for agitation, try using low doses of clonidine also.
Only okay. I've not tried clonidine.
So there is a question by Dr. Padul. In your practice, which drug have you used the most with the good results for insomnia?
I wish you wouldn't say insomnia again, because it's sleep-related issues. I mean, everybody doesn't have insomnia. So insomnia is a total lack of sleep. So we have to be careful when it's just like depression for any kind of sadness. So be careful when we use terms in terms of, so there's a tendency to kind of just say that person has depression, that person has insomnia. So please be careful when you use terms, when you label, it's almost like labeling. So I probably, again, I can't say which medication is the most useful because it depends on what condition it's about. So um, if it is sleep and anxiety, I use mirtazapine a lot. When it's agitation, I use quetiapine a lot. And see, because I'm a psychiatrist, I'm very confident in using doses also. So if I see a clear psychiatric disorder, along with it, we use 50 to 100 milligram of quetiapine very easily, very confidently. So, and we also are good at combining medications also. So, but for in palliative care, I would say probably quetiapine and mirtazapine are the commonest medications that I would use, and of course sometimes benzodiazepines. Any other question? Shall I go on to self-care? How common
I
is
think
hyponatremia in elderly patients? Is there any risk factor for increased incidence? What are the precautions should be taken? I haven't actually looked into the evidence in terms of the prevalence. There are reports. I can get back to you after checking evidence of the, I mean, how much, I haven't looked into how many people, but it is quite common in elderly. It's quite common in elderly. I would probably look into, when you look into, if there is a previous episode of hyponatremia, or if there is a person is already on medications causing hypotension, like orthostatic hypotension, like antidepressants, tricyclics, or any other medication which can, cause fall in BP, then I would not use SSRI. Generally, I would not use SSRI in an elderly person. I would use mirtazapine or stablon. Does that make sense? I don't know who asked the question. So
Is it okay we can, or is it okay which we can use vasopressin, antagonists like tolvaptan along with it?
why do you want to go to, why do you want to add a medication just to you are expecting hyponatremia and you want to add another medication just to avoid
No,
that?
if the patient is controlled with SSRI with that particular medication.
If the person is controlled and there are no side effects, then you don't have anything to worry. You have to just carefully monitor them.
No, if he goes into hyponatremia, and that's the only side effect.
I wouldn't see in palliative care, we take care to reduce the number of medications that they use. You don't want to keep adding to the person. So I would rather choose mirtazapine or some other medications than add another medication. And what is the cost of that medication? The other medication?
Yes,
Tell
it's
me.
costly.
Then why do you want to think of that? Is that it? Shall I go on to self-care? That would be only few slides. Oh, okay. So I'm just using some slides which we, because this was a big, important topic that we addressed during COVID. And we did a lot of teaching during the COVID times on self-care. So I'm using the same slide. So on the slides, you can see the logo of Parliamentia as well as the group that we did, Pali COVID Kerala team. So One is about the stress that any kind of situation leads into, like for us, if you're talking about self-care, especially I'm giving you an example of COVID. So many healthcare workers are forced to encounter situations where they have to tell grieving relatives, we did our best with the staff and resources available, but it wasn't enough, rather than saying we did all we could do. And this is a seed of moral injury. It could be traumatic and lead to a post-traumatic stress disorder in many, if not all, of our health workers. And I think this was very common during COVID, but this is quite sometimes it can mirror some situations that we go through in palliative care also. When people come with the enormous suffering, we encounter situations where it's very difficult to tell the grieving relatives that uh, sometimes you have, like you said, we do not have enough resources to help them completely. So we can do only our best. And suppose a person also comes from a poor socio-economic status, looking at, the ethical problems that come, we choose a certain strategy to be implemented for that person. And sometimes you have to tell them that we are doing our best, but it might not be the most ideal way to manage this person. But in our settings, we can only do so much. So when you talk about self-care, you have to know these terms that we talk about. One is moral distress, which I just talked about, moral injury, where, it is related to a situation in which clinicians or carers are asked to carry out acts that are contrary to their moral beliefs. Like, sometimes you have to deny beds, or, you have to deny a home visit to a person who you think deserves, but you have to actually attend to another person who is having emergency or an urgent issue. So sometimes we have to justify also, sometimes helping out, sometimes you cannot help one single person because we need our resources to justify the care for around 100 people that we take care of. So that kind of moral distress can happen. Compassion fatigue is common in palliative care as well, where because of the relationship between the clinician or the carer and the patient, there is a kind of fatigue which comes because you're constantly giving, you're giving, and you feel that you're being depleted of your own energy. So that compassion actually takes away a lot of energy from you. And of course, burnout, which is very common because of the work environment. So three kind of different situations, and they are all related to each other also. So it's kind of, can lead to one another and can overlap with one another also. We have to really, so when you think that self-care to any one of your team member or yourself, you need to identify why this is happening, just not that you're tired or you're emotionally showing something which you are not identifying, but understand where it comes from. So you need to understand that these concepts exist. So, when you, for example, remember that other dynamic curve, that dimensional curve that I showed. Similarly, you can look for stress level also. Like, when you are, when there's little stress and you're laid back, and when there is optimum stress or too much stress, how fatigue can become exhaustion, and then burnout comes with anxiety, panic, anger, and then a breakdown. So when the stress level increases, and this was very much visible during COVID, and that's why it became a big uh, topic of interest and topic of discussion. But I think in palliative care also, we do really work, bearing the stress, and much of the staff stress comes because of um, uh, how we perform and how we are using the support systems around us. So to understand burnout, it's got three components. One is emotional exhaustion. That is, there's a feeling of energy depletion or exhaustion. You just are not able to really show any emotion, negative or the positive. You're just so depleted and detached. So that shows that you become detached even with the work that you do. So you're not motivated to go for the work. And also because when you feel like that, it leads to a feeling that you're not actually doing the work well. And so you think you perceive reduced professional efficacy, and then you have a low personal accomplishment and low self-esteem. And then there is also a depersonalization. That means an increased mental distance from the job, and also sometimes feelings of negativism or cynicism related to one's job, like saying, why are we doing this? It's not making any changes, we are just working and but to no good end kind of thing. So all this are the components of burnout for identifying. So this is important to understand, to identify in yourself as well as in your team members. For example, let me just uh, talk about the COVID-19 pandemic. So there were risk factors like disturbed work schedules, extended shifts, disrupted sleep patterns, exposure to morbidity and mortality, frequent changes in practice and decision making, information overload, inability to deliver care despite taking an oath, worry about risk to self and family, separation from family and loved ones, pre-existing and mental health and addiction issues. And when you think of palliative care, except for few of these, like probably the worry of risk to self and family, um, many of this are a bit, you can see that it happens in palliative care as well. So you there is actually, this person feels really really stressed, and sometimes becomes very hostile. um, there's anxiety and fear, there is negative feedback. So we need to be careful about this. There's a lot of evidence about burnout also, not in India as much, but in the US statistics, 54.4% of physicians have shown at least one symptom of burnout. 10% of employees reported having a high level of post-traumatic stress, during the SARS outbreak. So compared to medical staff working on the usual wards for infected patients, those working on COVID-19 frontline had lower frequency of burnout. So there is something like that also, when, because there is also um, uh, the feeling of, you're doing something for the people. So there is the that only when that balance goes, then you go into burnout. So a lot of data after COVID came out in terms of burnout. So again, the same slide about bringing in meaning is very important in terms of how you can maintain hope and meaning in your life and the purpose in your life as a healthcare professional. Teamwork, establishing and maintaining a sense of belonging at work, enabling and building emotional and social connectedness. So having the team engage, having harmony, having team meetings, debrief sessions, having a buddy or a work um, partner, so that you don't work alone, but work as partners when there is a crisis, and focusing on the blend of work and life as well. So you remember that you also have a family and other interests, and how do you maintain a balance on that? So again, reducing burnout is personal care, sleep, nutrition, exercise, relaxation, meditation, breathing, good work balance, personal time to grieve losses. Organizational is resources, supervision by the team leader, work-life balance. One important factor is recognition and reward, acknowledging that the person has contributed to the teamwork, mentoring, regular discussions, and the professional, like your own communication skills, your clinical, you get increasing your competence, by doing extra training, extra courses, improving your assertiveness skills, doing research, teaching, etc. are ways to reduce burnout. Interventions at the organization level. So if you have a team of your own, you're running a unit of your own, look at restructuring, empowering, retraining, look at the safety of your team, equipments available, predictable schedules, and the process, their standard process, the SOPs. At the team level, have clear goals, it's always good to start with a very quick team meeting and saying, what are we going to do today? What is, what are the plans for today? What are the agenda today? Have clear goals. Remember to keep repeating or reminding the guiding philosophy. What are we here for? What is the goal? What is the vision for our team? And also to know that their responsibility is shared and it's not an individual carrying the responsibility on their shoulders. So if a nurse makes an error, try to be compassionate, be objective about it, try to point out the errors, but also offer support. Or, especially when an error is by someone down in the hierarchy, it becomes difficult. Have buddy systems, like I said, have interactions, feedback, debriefing, online counseling, especially, this was for COVID times, time for learning, welcoming people, celebration, encouraging others is very important. Enjoying time, talking about family, remembering things that you like, not talking only about illnesses and patients, but also have time to kind of have a break in between, celebrate birthdays, etc. And as at an individual level, get help. If you think you have a problem, please seek help. Seeking help is a sign of strength and not weakness. Have timeouts. Realistic and gratifying goals should be kept. Self monitoring, pacing activities, relaxation, mindfulness. Have a sense of hope, realistic hope, and also use your family and friends well. So self care you have to maintain meaning and in the practice by a proactive and holistic approach. And the personal health as well as well-being is important to support others in your team. And there should be a referral for mental health assessment. When somebody is expressing suicidal ideas, they do not directly do so. So if somebody is seen to be very gloomy, saying that they are fed up, please get them, see someone in. When there's violent or aggressive behavior, uncontrolled use of substance like alcohol or drugs, crying or expressing uncontrollable distress, unexplained bizarre behavior like talking or smiling to self, significant deterioration in occupational functioning. If their performance really declines, please do that. So I'm stopping this also and I'll wait for questions. Any questions? I suppose the silence is because people are reflecting and not because of information overload. But then you asked for it today. What is the silence behind? The silence is, I need some interaction. Otherwise, the session cannot go on.
But most of the time, I have found I'm helpless when I find that the caregivers are detached from the patient's condition. It happens.
Caregivers
Are detached from the patient's condition in the sense that they don't bother much about the patient's condition, even if we tell them to interact with us and give us feedback as to
How
what the
common
condition,
is that?
especially when we.
How common is that?
I've
I
seen,
don't think
I've
it's very
seen it
common.
quite a few times. I've seen it quite a few times, but it just actually surprised me why they do that. I used to keep on asking them, why don't you give me a feedback? I tell them to give me a feedback as to how the patient is progressing, but I have to keep on calling back them to get the feedback.
But I think in that you have to explore further about their distress rather than assuming that they are not cooperating with you. Probably you should send your social worker or someone to kind of spend time.
Why? Quite a few times I have failed to understand why, and that's why I ask any
You
particular
should ask
reason.
the
But
help
because
of someone. That is why I said you should take the help of someone who can address such issues, like a social worker who knows how to deal with family dynamics well. So,
interact with them.
yeah,
Okay.
rather than assume that they are not.
Sometimes the problem is we don't have access to social workers when we are working on the private, so that's the problem.
You have to find
So,
resources somehow or the other,
okay.
because otherwise, that the tendency for us when we do not get the outcomes that we expect is to assume or attribute to others. So I wouldn't. I mean, for an equal. I mean, if you're asking me that people do not take care of their patients or do not come back, there are so many people who do the other extreme also, isn't it? So it's not a common. I mean, it's not that everybody does it deliberately. Of course, there are some people who neglect their family members, which is evident because of conflicts. Like I said, then the conflict resolution should be our main intention. So we cannot say that they are not doing it. There is some reason behind it. So we need to explore further.
So it's better to involve somebody from the
Yeah, and your
psychology is
team,
as effective.
psychology, social work, your own nurses, I think they would know better in terms of their family. They spend a lot of time with them. So there would be a nurse who is, communicates well, take her for a home visit. I think they can spend time, talk. Even when you go for a home visit and see how, you spend time regularly at their home, they will start engaging with you better.
Yeah. Okay. Yeah, sometimes they are not very open to us. That's why.
Yeah, that would be there. I mean, people are of different natures, isn't it? Some people do not cooperate. Then we have to, when you have 80 people cooperating and 3 people not cooperating, then you will take it along with your. So that's the way things are. It's just like some symptoms respond and some symptoms don't respond.
Thank you.
There is a similar comment from Dr. Yadav who says most of the caregivers in our surgical practice tend to be fed up if the patient is held up for more than 3 to 4 weeks. Then they start saying it would be better. ഇങ്ങനെ കിടന്ന് നരകിക്കാതെ അങ്ങ് പോയാൽ മതിയായിരുന്നു.
I think I would probably say that in all these things, we have to uh, actually spend time with the caregivers. You cannot tend to. There would be some caregivers who are not cooperative or who are very frustrated, but I would probably say that the may what as a guideline I would say that we should not assume that they are hostile or they are frustrated. We should not come to conclusions, but we should try to find out what's happening.
Ma'am, it is not about being fed up. It is not about being angry. It is not about being there fed up with all this care they are able to give. It is about their own livelihood because they are held up in the hospital. They are very poor patients and they cannot go for work. This all goes to they started saying like this. Actually, it is not that they don't love their father, mother, etc. But the problem is that it start affecting their own life.
But there is no solution for that, isn't it? We have to
Yes.
sit. So that's like a problem solving therapy. You sit with them, you try to find out the priority is like if there is, then we need to find out whether somebody else can come, that person can go and work, try to find people who can come in alternate days. Is there another carer who can come? So you have to find out something like that. These are not actually really emotional distress states. These are all issues which come up in daily logistics as far as I am concerned. So we are talking here about self-care. We are talking about emotional distress. So I'm not getting questions on those aspects. You're talking about
One
difficult
question, sir.
situations. We are talking about difficult situations that come in your practice. Isn't that
There
true?
is one question.
And that should be done by how do you approach these difficult situations using your teamwork? How do we address, how do we communicate with them? How do we identify what is uh, leading them to say this or leading them to not cooperate, and try to facilitate um, to find a way out of that. How do we do that? Sometimes we will not, if the person has to be in the surgical for ward for 6 weeks um, to get better, and if there has to be the carer, there is no other person who can be there, we cannot, we should, there can be nothing which we can do. We have to sit and reassure the person and give them good support when they are in the ward.
That is a question by Dr. Gajaswara. He's asking about when to start antidepressants. Any specific questions to ask or any signs to exit?
I thought we did that last time when we described distress. You screen for distress and you looked at the score, isn't it? And then when you also categorize that, I did give the signs and symptoms of adjustment disorder, depressive disorder, and anxiety disorder. So you have to know to elicit whether there is significant anxiety by looking into whether there is increased, anxiety, increased worry. If it is depression, whether there is a low mood, whether there is anhedonia. Remember, I talked whether anhedonia is decreased, interest of, or ability to experience pleasure in activities they had pleasure before, and also whether there is, other, there's hopelessness, helplessness, worthlessness, whether there's a desire or wishes to die. So all these are the features that you would say would give you an indication that it is moderate or severe depression. And any of these symptoms of distress also should be linked with the level of functioning. Remember, I said biological functioning, uh, interpersonal functioning, and occupational functioning, to check whether the person is coping or not.
Yes, ma'am. Just one thing, ma'am. Like most of our patients have these symptoms, ma'am. Like most of the patients have the similar ideation when they refer to us, ma'am. So, so that was my main question, because like we are tending to like start it at the first time we see them, or like we need to take some time to start medication. That's what my main query was, ma'am. Like, because like everyone is having the similar symptoms, and we are not able to assess that like this person needs to start on antidepressants or something.
That's why I
Uh,
said you need to have a measure like a screening tool. So when CP, because it's a subjective way of expressing, people might talk about emotions. Remember, I don't think anybody went through the last day's presentation. So I think you need to know that emotions are expressed, but when we want to look at signs and symptoms of the emotions, we need to look at whether they are persistent, pervasive, or the intensity of the symptoms. So if a person is continuously expressing it, you
okay.
screen the person with a tool, and you also then take the help of a mental health professional if you're not able to do on your own. And if you think most of your patients are having this, then it is an indication that they are having distress. And that is what evidence also says, that around, uh, s- uh, 60, so much 30% of people in oncology or in palliative care have psychosocial distress. So it is not an unusual occurrence. So what you need to do is have that system of assessment, screening, and management incorporated into your system. So
Oh, okay.
have the routine screening happening, have a social worker in your team who can address this, and have a license. Even if you don't have a psychiatrist or a psychologist, find someone whom you can license with or come once a week to your department who can help you.
Because the main thing was like, ma'am, do we start it the first time we see them, ma'am, or like can we wait with the tools? Because like sometimes they
I can't
went out.
help you. I can't help you with that.
Oh,
That's
okay.
why I'm keeping on saying that it depends on the
Oh,
intensity, the pervasive type of symptoms, and the. So suppose
uh,
a person comes with a suicidal attempt, then probably immediately you
uh,
can start. I cannot
oh,
say that for everyone you should start at the first or the second
uh,
or the third visit.
okay.
How can you say that? It's a very, it's
Very
emotional
subjective.
distress. It's not like a pain, no.
Uh, yes, ma'am.
The more that this is also due to see, the thing is, if you start addressing, communicating about it, and start assessing distress, you will become more skilled to understand the distress. You become better, your competence also increases.
And
but you
the
but
main
usually
thing.
but usually what happens is people do not address it. You identify it, but then you do not address it, you do not manage it. So uh, what happens is this helplessness continues.
Oh,
So
okay.
if you start addressing it, talking to them, so when you
Mm,
identify that, half of the time is us feeling helpless and attributing it to several other reasons, or assuming that this is due to this. It happens unconsciously. I'm not saying all of us do it deliberately, but what
mm,
we do is very it's an unconscious way of doing it. We just assume that oh, this person is very poor, his daughter is not married, that's why he is sad. Or he's got so many symptoms, he is sad. So we ourselves do that process. We do not address it in a structured manner.
Okay. But in case we need to start, is there any medication that is like much safer to start with them? That because like there are many medications that as such like we are very confused to start which one to give. So
I
that
thought
that was
I did speak about
yeah.
medications today.
Yes, ma'am. You
Yeah,
did
I said the
tell me.
SSRIs are the safest.
Yes, ma'am. Okay. Because like we sometimes we tend to start some we olanzapine and all we start sometimes.
That's
For
because you are not see. That's because
uh,
there's always a confusion between antipsychotics and
yeah.
antidepressants. People do
Uh,
not read about it and
Correct. So
prescribe medications because they think that
uh,
will be useful. So there are definite psychotropics have definite categories of medications, classifications of. So you have antidepressants for depression, you have antipsychotics for certain symptoms. So you need to know which is which. And antidepressants are one of the easiest group of drugs that a primary care physician can use.
okay. And sure. Thank you, ma'am.
I think what you should do is you just read the guidelines or the medications and start using that in the sense that when you think that a person is has some significant anxiety or depression, what you
Mm,
should know is start using SSRIs in its low level. Have a person you can liaise with. Start
yes.
using medications and then you discuss with the psychiatrist or a mental health professional.
In
Start
case we
doing that.
start, ma'am, how long do we need to like assess them for like any improvement or any symptoms?
So an antidepressant takes
Yes,
at
ma'am.
least 2 weeks, 2 to 3 weeks. So
Oh,
I would wait to increase the dose for 2 to 3 weeks, and then it has to come into the effective dose. So uh, you would probably give for 2 to 3 months for a person, and
oh,
a person who has depression, probably I would continue the medications for 6 to 8 months before stopping it.
okay. But if we some of them like are very coming in the like very late stages now. It's like
Late
maybe
stages
they
of
have
what?
few months. Late stages of the disease. No? Like uh,
Yeah.
we deal with like last few months in life. That's what
Yeah.
we
So
get.
then you have to start the medication as soon as possible so that they get the benefit of antidepressants if they are depressed.
Okay. Okay. Thank you, ma'am. Thank
What all of you can do also is that I don't know if it's possible in your settings. Try to have a license with someone in your hospital who will be willing to come in, do a few sessions for your, team in terms of, or even demonstrate or suppose you feel one of your patients is having anxiety or depression or some distress, going with that patient to that psychiatrist, sitting with him and help observe how these symptoms are elicited, because it's often very difficult when it's an emotional symptom to clearly tell you how, because it has to be elicited with your uh, the competence to look at the intensity of the symptom, how it's affecting several domains of the life. You have to keep doing it. So when you see people with experience and training do it, you understand that much better.
Yes, ma'am. The only issue is like having everyone together in the team is a big issue, ma'am. Like because like everybody has to have the time and then like the patient has to see many people. It costs them also. If you come in a private sector, it costs each thing. So that's the other scenario we are.
Yeah, but I think even in private hospitals, there will be some people who are willing to liaise and have
Okay.
programs which integrate. So it's also rather than assuming, you should just sound it out to the Department of Psychiatry
Uh,
in your hospital, saying that, see, actually we are seeing this. How can you help us?
okay. Yeah, definitely. I think they will try to. But the only thing is like the patient needs to pay each time they see each
So
one.
that is why I said rather than the patient going there, if you can ask the psychiatrist to come once a week to
Okay.
your team. And when
Okay.
he assesses, have a few members of your team who are interested in this aspect, sit with him, observe, so that they become empowered with the skills. So then they
Okay.
can help the other persons in your team.
Sure. Because I feel very awkward, like because sometimes I try out with patients, but I don't know how long to try.
No,
And
see, I wouldn't be able to do a surgery, like just come and
yeah,
do a surgery. You can't expect. So I
yeah.
wouldn't even try to do it. At least you're trying to do this. So I wouldn't even
But
try, isn't
I
it?
feel
So
very
you can't,
awkward. I
you
feel
don't,
very upset
no,
about it
that
sometimes. Am I doing the right thing?
because of the training. It's
Um,
not because of anything else. It's because we have been trained to address this repeatedly. So we are
yes.
confident. We know what to ask. We know how to assess the mental status examination quickly. Uh, we, because of experience of seeing various type of people, we are able to really come into conclusions quickly. But that
Yep.
you cannot. There is no short formula for that.
Okay.
That's what I'm trying to tell you. It's just like surgery. You knew a surgeon, how he does, and an experienced veteran surgeon, how he does surgery will be very different, isn't it?
Yes.
So you need to keep doing it, improve your competence, take help of others.
Yes, ma'am. Thank you so much. Really useful one, because like every day we come across these, and
It's
it's
very
like very
common
rare.
because emotion is part of you, isn't it? Nobody can escape from it.
Yes, ma'am. Thank you so much, ma'am.
Thank you.
I think
It's time.
one more question. Yeah. So today we went through the treatment of anxiety, depression, um, and self-care, um, then sleep disorders, which I think is one of the most important symptoms in not only in palliative care, but in any patients you see. So it is very important to understand that what is the basic thing that is causing distress, or what is causing the sleep disturbance. Uh, even in self-care, we have to find out ourselves what are the things which cause distress with us. So this question should be there always in our mind. What is it causing? Uh, so mm, we it is very difficult for us to understand all the specialized things, but we can always do the basic things, and like screening tools, NCC and the step thermometer, etc. That can be used, and the PHQ-9, which we already talked about in the last class. So please go through that, and you'll be able to understand the basics of mental health uh, issues. Um, so thank you, Chitra Madam, for
Thank you.
two wonderful sessions with us. And
Yeah, I just wanted to say that I just sent a message on, it's very difficult because mental health issues are very diverse and vast, so to cover all of them and to make complete sense in on 2 hours is not easy. So what I expect from you all is to just at least understand the basic issues that would come, and probably also think that there are other ways of looking at distress. And I would always suggest that if you feel that you're not able to manage, take the help of someone who is trained, so that the benefit should be for the patient. Thank you so
thank
much.
you.
I think I have, it's like
Supriya,
Thank you, Chitra ma'am. Thank you so much for joining us again and taking us through that wonderful session. And we hope that we have kickstarted a journey of 1,000 miles with these 2 steps now towards ensuring mental health for the caregivers, the patients, as well as self-care. Thank you so much. And thank you so much, everyone, for making the sessions interactive. With the promise that we'll be meeting again in another session with another eminent faculty. This is Sri Priya, along with Dr. Chitra Venkateswaran and Dr. Sunil Kumar, signing off from the Pallium India's desk. See you in the
Thank
next
you.
session. Till then, everyone, take care. Bye-bye.
Bye-bye.